So happy to have my friend and colleague, Amber Cipriani, to talk with us about integrating germline pharmacogenomic testing into oncology care. So Amber is a clinical pharmacist who specializes in oncology care and pharmacogenomics. She currently serves as the Precision Medicine Pharmacy Coordinator at the University of North Carolina Medical Center. She enjoys genetics. Before going into pharmacy, developed a companion diagnostic genetic test. She is joint funded with the Eshelman School of Pharmacy, where she coordinates courses and teaches classes, and participates in multiple state and national groups working to implement pharmacogenomic testing. So thank you, Amber, for being here. Outside of your professional bio, anything you'd like to share with our audience about yourself?
So I currently have 2 small children, so I was thinking, what are my current hobbies? And so right now I'm trying to understand toddler behavior to prevent biting. So if anyone wants to give any feedback about how to prevent chronic biting in an 18-month-old, I'll take that feedback.
Yeah. Oh, good luck. So here is what Poll Everywhere will look like. This is a sample. Join pollev.com, enter UNC-LCN. You will have a chance to practice in a moment. Here are our disclosures. And we have some participation. So our first practice question to get you set up with Poll Everywhere: pharmacogenomics is the study of how multiple genes, i.e. the genome as a whole, impact drug metabolism, efficacy, and toxicity. True or false? So it looks like we have 100% true. How'd they do on their practice?
I think they did pretty well. We'll talk about some of the semantics you might encounter, I think, in the presentation.
Great. So now I will turn it over to Amber.
Awesome. Well, thanks for the introduction, Tammy. I'm happy to be here. We're going to talk about pharmacogenomic testing in oncology care today. These are our learning objectives, so I cannot cover all of this in 1 hour. I'm going to try, but there's so much to know. So I want you to come away with some really strong examples of pharmacogenomic relationships for oncology medications. This second learning objective is where I really want you to pay attention. I want you to come away with some resources to aid in interpretation and application of these tests. So you saw I'm a teacher, so I'm hoping that you'll have your laptop or your phone available so that when I give you some of these resources, you can kind of test them out during the webinar today, and maybe come away with some great bookmarks in your bookmark bar. And then lastly, I'll describe some clinical workflows that integrate pharmacogenomic testing that are used here within UNC and also at some other institutions. So I'm starting you out, putting you to work with a Poll Everywhere question. So I'm really interested to hear from you, the audience, about whether you currently use genetic testing when caring for patients, and maybe a few words about how you use it. And so I'll give you a couple minutes to let me know where everybody's at with this topic. And maybe, Tammy, do you use pharmacogenomic testing in your practice?
Well, yeah, so I think when you say genetic testing, maybe clarifying for the audience, right? I think when you were saying about semantics, the words we use is that genetic testing to check for, familial cancers, or is there some additional testing related to, how we administer our medicine? So I don't know if that, I'm assuming your talk gets into all of that, and maybe that was the point of your generic question.
Yeah, that's great. Yeah, I think it's hard, to know if you're using genetic testing. Sometimes you don't know if you're using it or not. So So a couple answers. I have a yes. Yes, mostly germline and integrating more of neogenomics. Okay, so we're going to kind of get into this. I'm going to move on for the sake of time. So some background information here. So my position when I was introduced is in the area of precision medicine. Pharmacogenomics is part of precision medicine. I think this term gets used a lot. And so I have some definitions here, again, getting into the semantics about what it truly is. This first definition, precision medicine initiative, so this was legislation that was started during the Obama administration, and their definition in this legislation was an approach for disease treatment and prevention that takes into account variability in genes, which is what I'm going to talk about, but also things like microbiomes, environment, lifestyle. So precision medicine encompasses more than just genetics. When we talk about genetics, it's sort of, I guess, a branch on the precision medicine tree. I have the FDA definition there as well, just to underscore that genetics is one part of precision medicine, but there are other aspects as well. And then I get this question a lot, and the true-false question at the beginning got at this. Sometimes you hear pharmacogenetics and pharmacogenomics. You already heard me sometimes use those terms interchangeably, and I think most people do, but if you're a purist, pharmacogenetics is really looking at how a single gene impacts drug metabolism, efficacy, or toxicity. So you're looking at a single gene and usually a single drug. Pharmacogenomics, you're trying to integrate how multiple genes or even the whole genome, so your collection of genes, impact drug metabolism, efficacy, and toxicity. So a little nuanced. You'll hear me use these terms interchangeably, and most people do, but if you look at the true definition, that's the difference. And then the other thing to help us with just baseline sort of information is thinking about germline versus somatic mutations in DNA. And so when we're treating a patient with cancer, we actually are looking at two different sets of DNA when we're talking about pharmacogenomics. So the tumor itself actually has its own genome that's separate from the genome of your normal cells, okay? And so both of those genomes can be important when you're trying to figure out how to best treat a patient in oncology. But when we're looking at germline genetic testing, we're looking at genes that are heritable. So these are genetic changes that you inherited from your mom or dad. These mutations are in all cells, and the test that we can use will either do a blood test or a cheek swab. So we're able to test for these genes in normal tissue. When we're talking about somatic or tumor mutations, these are often not heritable, although sometimes they can be, but they're usually not inherited from mom and dad. And they're tumor specific. So oftentimes these are mutations that are in tumor cells, but not in normal cells when we test them. These somatic alterations can be detected with a tumor sample or a blood test. I won't get into sort of why you can use a blood test for both, but it's just really important to think about what genome are you looking at? Are you looking at the inherited genome, or are you looking at the tumor genome? So the first section of this presentation, I'm going to talk about pharmacogenetics and oncology, specifically around tumor biomarkers applied to drug selection. So I'm first going to talk about how we use genetic testing of the tumor to figure out how to best treat a patient with cancer. And so I'm going to start us off with a case. This is a 51-year-old who presented with shortness of breath, got a chest x-ray, and was found to have a mass in the lung. They do a biopsy of this individual, and he's diagnosed with metastatic non-small cell lung cancer. In lung cancer, it's pretty routine to do this somatic testing. So for this patient, we actually took a piece of that biopsy and sent it off for genetic testing of the tumor. So again, here we're trying to find DNA mutations that are specific to the tumor, not that this person has inherited from mom and dad. And what we're trying to figure out here is, can we use these mutations to best select therapy for this individual? And so I have an example of what the results from one of these genetic tests might look like. And if you're unfamiliar with them, what it looks like is an overwhelming pile of alphabet soup. And so I'm going to briefly decode what this all means. Maybe you won't be able to interpret everything, but just to help you decode the alphabet soup, and then help talk through what are some resources you could use to help understand this on your own. So the first thing to talk about are how we did the testing. And so most tumor somatic testing is done using what's called next generation sequencing. And all that means is that we are sequencing the DNA faster. We can do it pretty quickly. And I have here on the bottom, I really like this picture. When I explain this to patients, I tell them to think of it as a fancy spell checker for their tumor DNA. So the sequencing machine is looking at all of the different letters in their DNA, which is written instructions for their cells, and trying to find where are the mistakes that turn that normal cell into a cancer cell. Usually when we're talking about somatic testing in cancers, most of the assays that we're using are pretty large. And so I have on the table on your right a list of some of the labs that are currently in use here at UNC. This is not an exhaustive list of available tests, but you can see that the number of genes that we're testing is anywhere between 100 up to almost 650. And so we get a lot of genetic information from these tests. I think it's pretty overwhelming, and so what I'd like to leave you with are just some tools to sort of figure out some of these results if you need them. So this, going back, is the example of the results from our lung cancer patient that we talked about. And I'm going to talk through trying to decode some of this alphabet soup. So this particular test, they tested over 300 genes. And you can see here at the top, and I don't know if my pointer will work. It's not working. You can see there at the top, genomic alterations identified. And there's actually 3 lines listed. We're going to talk through what a couple of those lines mean. And so I have them pulled out there on the right-hand side. And so the first thing in this alphabet soup of results that's listed for you is going to be the gene in which they found the mutation. And so the first however many letters is usually referring to the gene name. The important thing to know is that we're doing a DNA-based test, but we're actually concerned with what happens to the gene product, which is the protein. And so everything that comes after the gene name oftentimes is telling you what's changed in the protein. In this case, the 2 gene names listed there are EGFR and TP53. In genetics talk, we usually do just use the letters, and if you really wanted to get fancy, I'll show you some resources where you can figure out what the E, G, F, and R stand for, but it's really not important. We refer to them by the letters. The next thing you have to figure out, the gene name, is what actually happened to the gene. And so the next part of the alphabet soup is trying to tell you what actually happened to the protein. And so these letters and numbers are talking about actually amino acids. So I'm asking you to dig way back into your science background to think about the fact that proteins are made of amino acids. And that's what this section is actually telling you. This is sort of if you're visual like me, reminding you, remember, proteins are made up with these amino acids, and the amino acids have these abbreviations. There's 3-letter abbreviations and 1-letter abbreviations. This is showing you a list of the 3-letter abbreviations, but actually these reports use the 1-letter abbreviations for the amino acids. So looking at the first one, EGFR, what it's telling you is that in this particular patient's tumor, there was a deletion in exon 19. Exons are coding sections of the DNA, and that E746 is telling you normally at the 746th amino acid in EGFR, there's an E amino acid, which is actually glutamate. And then it's telling you all the way to the 750th spot, which is normally an A, alanine, there's a deletion. So what this is trying to tell you, this result, it's saying in that EGFR protein, 5 amino acids got deleted because of this change in DNA. The bottom one is trying to tell you a similar story. It's telling you in that TP53 protein, There's usually an R amino acid in the 213th spot, but it gets replaced with a Q. Now, all of this, letters and numbers, generally means nothing to most of us, right? Because you don't have a map of these proteins in your head. But what we do know is that a lot of the alterations that are reported on these tests, we've figured out that they actually drive tumors to grow, and we've identified some patterns. And so once we have these somatic tumor testing results and we know that there's a change in the tumor that's driving cell growth, we can figure out, do we have any drugs available to target it? It's important to know exactly what your change is, because a lot of these drugs that I'm going to show you are specific to the type of change that you see on the report. This is kind of a chart showing you specifically in lung cancer some of the patterns that we see. And so if you're someone who wants to develop a drug, you might look at a pie chart like this and say, gosh, 30% of lung cancers appear to have EGFR mutations. I got to figure out how to develop a drug that targets those particular mutations. And that's what we're doing therapeutically now. I get excited about this because a decade ago, this was just a pipe dream to have personalized medicine where you do genetic testing and then pick a personalized treatment off the shelf. But this is really a reality now in cancer. This is showing you, for lung cancer anyway, all of the biomarker-directed treatment that we have. And so really the process is you do genetic testing in lung cancer, you figure out what alterations you have, trying to decode that alphabet soup, and then once you've identified those, you can pick off your shelf or off your options to see if there's something that is genetically targeted for your patient, and we have quite a few options. You'll notice for our particular patient, in the top left of this, I have EGFR exon 19 deletion, which is what we decoded on that report. And you can see for that particular mutation, there's a number of drugs that we could use. So this is leaving you with some resources to identify biomarker-directed therapies. So how would you do this? I've shown you a single example. But there's lots of information in disease-specific guidelines. So for example, if you're treating lung cancer, colorectal cancer, there's oftentimes information in those. The laboratory reports themselves, when you do this type of genetic testing, can help you identify when there are drugs that you might want to look into. There's also an FDA table of biomarkers and drug labeling. And that is searchable. So if you have a particular drug or a particular mutation, you can go there. My favorite resource that I'm going to ask you to test out today is OncoKB, which is in the middle. And this is oncology, precision oncology knowledge base. And I have some screenshots to show you a little bit further down. And then there's two other precision oncology sort of knowledge bases there at the bottom that we won't have time to get to. But OncoKB is my favorite that I'm going to ask you to pull up. This is a screenshot of the FDA table for pharmacogenomic biomarkers and drug labeling. It's also searchable. So if you want to make sure you're looking at things just that have FDA approval or FDA level vetting, this is a good option. Yeah, so you can bookmark it, or I always search it every time because my bookmarks bar is a mess. And then this is OncoKB, which I think a lot of people are not as familiar with. And so if you are on your laptop and not multitasking, you can go ahead and pull up OncoKB and try to click around and utilize it. Our particular patient had a mutation in that gene EGFR, and so on OncoKB, I'm going to go back a slide, you can see you can search by the gene, by the specific change, so you can search by EGFR and then exon 19 deletion. You could search by lung cancer, or you could search by drug, so there's a lot of ways to get to some of this information. If you were to search by, in this case, EGFR, this is what would come up for you in OncoKB. There's lots of cool things here. I can't go through all of them, but here it will give you, if you click that Show EGFR Background, information about the gene and the protein. It shows you what tumor types this gene is commonly altered in, there in the bottom right. And then in the middle is a lollipop plot of the actual protein itself. And so on the bottom is an actual map of each of the amino acids in the protein. And so for EGFR, it goes from 0 to 1210. And there on the y-axis is how many times they saw a mutation at that particular spot in this MSK impact study, which is a cohort of 11,000 patients. So it's essentially giving you a map of the protein and showing you how often do you see alterations in cancer at a given spot. If you scroll down on that page, you get to my favorite section as a clinician, which is some therapeutic recommendations if there are any. And so for this particular patient, you can see there's exon 19 deletions, which is what we decided this patient had mutated in their cancer. And then there's a list of therapeutic drugs. There's a level of evidence. In this case, it's level 1, meaning there's an FDA approval, but you can also get information on drugs for which there's lower levels of evidence. And then I've tried to sort of hover my mouse for you there. If you hover over the citations section, it will also pull up some of the studies that were utilized to come to that level of evidence. So if you're someone who ends up doing PubMed searches for these types of things, this is an easy hack to get to some of that data quickly. So again, trying to give you resources. If you have a genetic report, so I've kind of put that here in the corner of the slide. Maybe you can't make sense of all of this information off the top of your head, but if you plug it into a resource like OncoKB, it can help you figure out what does it mean to see these mutations come up for a given patient as far as therapeutic options. Once you know your options, then it, I think, becomes an exercise in, other reasons to use a drug. So we look at things like tolerability, dose, and any differences in evidence. So you might be asking right now, why would I put myself through all of this trouble to do this genetic testing, have to interpret these reports? And so this Kaplan-Meier curve is just to show you the impact that these targeted therapies can have in a lot of situations. This is an older study in lung cancer, so in 2011, that compared one of the first EGFR inhibitors, erlotinib, to a platinum doublet, which was our standard of care at the time. And so you can see the blue line there is if we give patients with EGFR mutations in lung cancer a platinum doublet, their progression-free survival was 4 months. So we used to see patients and we'd tell them, you have 6 months to live, you have metastatic lung cancer. That was the standard of care. These targeted therapies come along. They have different toxicity profiles. Some would argue they're better tolerated, they're oral, and they actually, in this case, almost triple the progression-free survival. So that's why we're going through all this trouble. But it's still important that you have the correct match, right? So these therapies have to be given to patients who have sensitizing mutations. All right, so I'm going to try and make you do this yourself if you're game and not driving or multitasking. So we have another case, and what I'm going to ask you to do as I read through this case is pull up that OncoKB website, and I want you to try to see if based on the genetic information I'm going to give you, you can identify if there's any biomarker-directed or pharmacogenomic-directed treatment for this patient. So I'm going to give you another lung cancer case, 53 years old with lung cancer. She undergoes genetic testing, and the results of her genetic testing include a MET exon 14 deletion and a TP53 substitution, so R175H, meaning there should be an arginine at the 175th spot, but instead there's a histidine. So I want you to focus on the MET gene. I'll give you that hint. And what I want you to do is try to navigate that OncoKB website to see if you can figure out if any of these treatments could be an option for her. So the options I have up here for you to choose from are osimertinib, olaparib, capmatinib, and crizotinib. And this is why I think we have to make sure we have good resources, because it's impossible for a lot of us to even say all of these drugs, let alone keep track of the genetic requirements for therapy. All right, so I'm going to progress to our poll everywhere, and hopefully we'll get some brave souls. Yay! Brave souls already.
I'm playing along with you, Amber, and I say C also.
Okay, good. All right, so I'll keep us moving. So C is correct. I thought I had screenshots here, but hopefully you were able to navigate there. Oh, I see one. A, so osimertinib would actually be an option for our first patient case who had an EGFR exon 19 deletion. So if you were looking that up, that would be true in the case of EGFR. But the correct answer here is actually C. And so what you do is search for that MET gene in OncoKB, and then if you scroll down to that therapeutic tab, you'll see that capmatinib is actually a MET inhibitor that is FDA approved in lung cancer for patients who have that particular genetic change. All right, so changing gears a little bit, I want to talk about if you're seeing oncology patients. We talked about the tumor makeup and how the tumor makeup might alter what drugs we use in patients. I want to pivot now to germline biomarkers, and I'm specifically going to apply those to drug dosing and selection in oncology. So for this example, when I talk about germline biomarkers, I'm going to talk a lot about how our inherited genetics could impact what are called pharmacokinetic relationships. So when I talk about pharmacokinetics, I'm talking about how drugs are either absorbed, distributed, or oftentimes metabolized or excreted by the body. So it's not, our previous examples were kind of more focused on pharmacodynamic responses, which are how are the tumor cells that have a genetic mutation going to respond. Now I'm looking at how are your inherited changes in drug metabolizing enzymes going to impact which drug I pick or how I dose it or your risk of toxicity. When we talk about, I call this classical pharmacogenetics, the words you sometimes hear are a little bit different. And so I'm going to also bring you back to a lot of very old biology that you might have gotten. We talk a lot about alleles, what alleles someone has. And so when I say allele, I'm actually just talking about the specific genetic sequence at a location. I think of it as the spelling of a gene. And so I'm saying, okay, what alleles does Tammy have? What spelling does she have that's different from me? We also talk about your genotype. So an individual's genotype is their collection of genes. Remember, you get one copy from your mom and one copy from your dad. We call those two copies your diplotype. And then what we do is we take those genetic spellings that we find for you, the spellings of the gene, and we try to translate that into what we predict your phenotype will be. That's the observable trait. And so I'm going to put that into a story in this sort of figure on the right. So when we do pharmacogenetic testing of drug metabolizing enzymes, what we'll do is we'll do a test. It'll either be a buccal swab or a blood test. And we will look for what alleles do you have for that particular pharmacogene. And so in this case, I'm going to talk about a gene called DPYD. Once I know what alleles you have, then I can put those two together to get your genotype. I'm going to say you got one from mom and one for dad. In pharmacogenomics, in this classical, we use the star nomenclature, which is essentially a nickname for the actual change. So you don't get that same alphabet soup, although it's there in the background. We kind of have a nickname for these genetic changes because they tend to be common across different populations. But that's all it's kind of saying. Instead of saying in EGFR there's this specific change, it's saying, okay, in DPYD we have a list of 20 or so expected changes, and we just number them 1 through 20. Once I have your different genotypes, I'm going to be able to guess what your phenotype is. So based on your genotype, I'm going to guess you have normal activity of a drug metabolizing enzyme, meaning it works as well as most other people. Or I might predict that you have better activity of your drug metabolizing enzyme, so it might actually chew through the drug faster. Or I might predict that you're a poor metabolizer, meaning based on your genetics, your drug metabolizing enzyme is a little slower. It's not as ambitious, I guess, as some others. And from that, I'm going to try to predict things about medication response. So I'm going to predict, will you have increased toxicity? Will the drug work better, worse? I'm going to try to predict that. So when you talk about this, I guess, classical pharmacogenetics, or when you look at the relationship with a lot of drug metabolizing enzymes, there's actually quite a few drugs that have what we call clinically actionable drug-gene reactions. And so interactions. This is taken from, again, the FDA has a table of pharmacogenomic associations. This reference is different than the one I gave you previously. But this is listing the drugs for which the FDA says, hey, if you have pharmacogenetic testing, there's actually some actionable things that you can do. And there's some favorites on here, which I think a lot of people don't realize. Proton pump inhibitors, we've got some pain medication, we've got drugs commonly used for depression. And so there's a lot of medications for which these drug-gene relationships exist. We just don't yet routinely do this testing. I'll be forthcoming. And so I'm going to talk to you about why, you might consider starting this and sort of our efforts in this area. The pie chart on the right shows you there's quite a few drugs that have these, but they're actually based on sort of a handful of drug metabolizing enzymes. And these enzymes also have alphabet soup names. Most of them are what we call CYP enzymes, which are enzymes that are expressed usually mostly in your liver that help metabolize drugs. But there's a handful of important drug metabolizing enzymes that sort of impact all of this long list of drugs. All right, so I'm going to give you another case. So and this case is a 55-year-old with colorectal cancer. His oncologist orders a DPYD genotype and finds that this patient carries a DPYD star 2A allele. You are seeing this patient to initiate cycle 1 of FOLFIRI, which is a combination of 5-fluorouracil, leucovorin, and irinotecan. And you see this genetic result in the patient's chart, but you have no idea what to do with it. I feel like this is probably most of us, right? So real quickly, just going through the drugs that this patient's going to get. The one of interest to us here with respect to DPYD is 5-fluorouracil, and this is how it's given. 5-fluorouracil is a cytotoxic chemotherapy agent. I'm so sorry, I have 5-fluorouracil and a picture of irinotecan, so I apologize for that. But this drug inhibits thymidylate synthase, and again, cytotoxic chemotherapy. So the adverse events we're worried about are bone marrow suppression and diarrhea are the big ones. It's used pretty commonly in a variety of cancer types. So if you were to go and try and figure out, I think, the metabolism of 5-fluorouracil, if you were to start there, this might be what you find. And so if you try to figure out, okay, what does this DPYD have to do with 5-fluorouracil metabolism, it can get pretty complicated. But I'm going to show you, actually, there's DPYD, which was the genetic result that you had. And I'm going to give you Taylor's version for all the Swifties out there. This is like the good version of 5-fluorouracil metabolism. And so what happens to 5-fluorouracil is it is enzymatically activated to you can see F-dump, FDTP, FTP. Those are the active metabolites of 5-fluorouracil that go on to kill cancer. That's what the crab means there. However, you also need to make sure that you're breaking down 5-fluorouracil so that you don't have too much toxicity. And that's where this DPYD gene comes into play. And so it breaks down the 5-fluorouracil into this DHFU that basically is excreted. And so you can imagine if you don't have the enzymes to properly break down that 5-fluorouracil, you're going to end up with a lot of those kind of toxic metabolites building up. Your body can't clear them, and you're probably going to end up with more toxicity. You can see I have capecitabine up there. That's an oral form of 5-fluorouracil, and so the relationship is similar between you need DPYD to break it down. And so it turns out that there is considerable difference in the activity of DPYD between individuals. And so this graph I have there on the right is a little bit busy, but what it's trying to show you is that the different colors represent different racial and ethnic backgrounds, and that on the bottom you can see there's normal metabolizer, which is NM, intermediate metabolizer, which is IM, and PM, which is poor metabolizer. And you can see that there's a subset of patients with all of these backgrounds that are either intermediate or poor metabolizers. Although I will bring your attention to the difference in scale of all of these bar graphs. And so the rate, we think, of individuals who are either intermediate or poor DPYD metabolizers is somewhere on the order of 5 to 10%, depending on the cohort of patients that you look at. So overall, the prevalence of this DPYD deficiency is rare, but the concern is that, especially in poor metabolizers, it can cause pretty serious toxicity to 5-fluorouracil. And so there have actually been fatalities reported in patients who are poor metabolizers or who lack any DPYD activity, who are treated with normal doses of 5-fluorouracil. We have some better tools available now, I think, to help prevent these fatalities in the way of antidotes and things, but it could still be a pretty big concern, and one in which if we have the results of pharmacogenetic testing and could integrate that into care, we could try to prevent some of these things from happening. So I want to focus on, if you encounter this in your practice, and it doesn't have to be DPYD, what can you do? So how do you figure out how to apply those genetic results? And so one resource you can look to are some guidelines by this group called CPIC, which stands for Clinical Pharmacogenetics Implementation Consortium. And so this is actually an international group of individuals, multiple specialties, that try to help make guidelines on relevant drug-gene interactions. And so these particular guidelines tell you what to do. They don't necessarily tell you you have to do the testing, how to do the testing, but they tell you if you have the results, what to do with it. So in our case scenario where you're looking in the patient's chart and you see genetic results but kind of can't figure out how to apply them, CPIC might be a great place to look. I will say the actual guidelines are, they can be difficult, I think, to interpret when you're in a clinic setting trying to see a patient and quickly apply them. So they're very useful and they're really trying to be evidence-based, but I think if I was sitting in clinic trying to figure this out quickly, it might not be the most efficient way to figure it out. Although this is kind of showing you that they do have recommendations that you could use. The other resource that I want to introduce you to is this resource called PharmGKB. So I showed you OncoKB, which is Precision Oncology Knowledge Base. This is actually a pharmacogenomics knowledge base. And so this is another sort of searchable place that you can go. You can search by gene, variant, or also drugs, so very similar to OncoKB. But this would be for medications that aren't necessarily specific to oncology and where you're looking at these more germline pharmacokinetic type relationships. So what should we do? So again, if you are trying to actively participate and try these things out, what I'd ask you to do is go ahead and pull up that PharmGKB website, and you can actually search for fluorouracil, which is the drug of interest here. And then you'll get a bunch of tabs on the side, and you can click prescribing info. Because again, I'm trying to help you figure out at the point of care, how can you help patients? And so you would be figuring out how to prescribe. That's where you click. This PharmGKB curates a lot of guidelines, but you can see it curates those CPIC guidelines. And if you click on the details, it will actually give you, I think, a pretty easy to use summary of those CPIC guidelines. And you can see at the bottom, if you have the genetic results, which for this patient you did, you can actually just put them in here and it will spit out what to do. And I'm not sure if I put, I think I said this patient just had star 2A, but you can see I've selected a genotype that would be a poor metabolizer. So you would see the recommendation here, which is there toward the bottom, says in this case you might consider avoiding the use of 5-FU or really, thinking about a dose reduction because there's a high risk of toxicity in this patient. So again, this is complicated stuff, and I think memorizing it is not the way to go, but the important thing that I want to leave you with are just where can you go to try to learn more about some of these pharmacogenomic relationships. So to sort of answer our case, this is a summary of the recommendations for dosing of 5-fluorouracil if you're going to consider DPYD, and what we do is assign an activity score. And so I'm not asking you to memorize this, but what I'm showing you is based on the genotype that we get, the result of the genetic test, we would try to predict what's the DPD activity, and then we'd try to integrate that into our approach to dosing for the patient. Now, this is not, I don't see this as a hard and fast rule, and every patient is different. And so there might be some situations where the risk or the benefit outweighs the risk, and you would continue sort of maybe with higher doses in a poor metabolizer. But having the genetic information, I think you can be empowered. How much should you dose reduce a patient? Should you monitor them more closely for side effects? There's a lot of other things that you can do to individualize care based on the result. This was a recent meta-analysis because I think we're always concerned, right? We're worried about toxicity, but the question remains, in oncology especially, if we reduce the dose, are we compromising survival? And this is not, a perfect, prospective study, but this is a meta-analysis in patients who received dose-reduced 5-fluorouracil based on the presence of DPD variants and then comparing them to matched controls. And at least in this analysis, they did not see a difference with respect to progression-free survival and overall survival, statistically significant. Although the PFS, I think, there warrants maybe a little further analysis. So what do the big guys say? What does the FDA say? So this is a really interesting example to me because the FDA actually recently updated the package insert for these drugs. And the reason they updated it was based on a citizens petition. And so a group of citizens actually petitioned the FDA to have stronger wording in the package insert to help encourage consideration of DPD activity when providers are dosing the drug. Still in the U.S., it's not uniformly, I would say, strongly recommended by all of the guidelines, but it's used a lot more in Europe, and I think we'll probably see it used more often, especially with the change in this wording. So this is a lot. Even in these two examples I've given you, there's a lot of information. It's a lot of things for one person, I think, to think about. And even if these are examples in your specialty area, I also showed you where there are examples of drug-gene relationships, probably that you had no idea existed. And so there are barriers, I think, to implementing pharmacogenomic testing and to being able to apply that information in routine clinical care. And so I gave you two examples. I gave you somatic testing, and then I talked to you about DPD testing for 5-fluorouracil. But I also showed you all of these other important pharmacogenes, and you're probably thinking, well, I'm not prescribing 5-fluorouracil, but I am prescribing ondansetron and tramadol and citalopram. And so I wanted to kind of give you a couple examples as we close of ideas about how we could incorporate multi-gene testing or testing of other pharmacogenes into clinical care. So this actually is our last case. Let's see, it's 447. I wanted to give you some practice using PharmGKB, and maybe we'll go ahead and do this, and I can talk while you're practicing. So this PharmGKB practice, so a 10-year-old patient with acute lymphoblastic leukemia, she comes in for a follow-up visit, and she's on a drug called 6-mercaptopurine, and her dose is 7.5 mg per meter squared 3 times a week. You pull up this drug, and you notice that the usual dose is actually 10 times that. And you look at her labs, her organ function's normal, her CBC is normal. And so my question to you is, you're probably thinking, well, gosh, this is a mistake, right? They underdosed this patient by 10 times. But I want you to pull up PharmGKB, search by mercaptopurine, and see if there could possibly be a pharmacogenetic issue at work here. I have some multiple choice options for you. So what could be the reason for this tenfold dose reduction of mercaptopurine? Could she be a UGT1A1 poor metabolizer, a NUDT15 intermediate metabolizer, a TPMT poor metabolizer, or is this maybe because she's a child and thus she metabolizes mercaptopurine different? So as you guys are kind of working through this, I will say a lot of the pharmacogenomic testing that we're doing now really centers around single gene testing, which I think some would argue is not the most efficient approach. So, for example, you're going to give a patient 5-fluorouracil, and so you only test for DPD. Another approach is what's called multi-gene testing, where you have a panel similar to what I showed you in the somatic testing example, where you're really looking at more than one important pharmacogenes in hopes that you can do the genetic testing up front and then apply that information if you needed to prescribe another drug that has a drug-gene relationship. So I see on here we have one answer. She is a kid, and so we do sometimes dose medications differently in children. In this case, if you were able to look on PharmGKB, go to that prescribing info tab that I talked about, you'd actually see that two enzymes listed on here, NUDT15 and TPMT, are involved in the breakdown of mercaptopurine. And so in this case, actually, for patients who are poor metabolizers of either TPMT or NUDT15, they require like a 10-fold dose reduction, especially for oncologic indications. And so in this case, C would actually be the most likely answer.
So as we are wrapping up, just a friendly reminder, if you have questions for Amber, please submit them through Poll Everywhere. We will spend a few minutes having an opportunity to talk to Amber. Thanks.
So here I have some screenshots for you if you weren't able to actually execute on clicking around PharmGKB. So again, searching by drug, and it actually will give you places where you can pick the alleles if you have a genetic result. If you scroll down, there's a synopsis there. So in the last minute or two, I want to talk about workflow solutions, and I like doing a game of Would You Rather, but it's like the G-rated version of Would You Rather. So this slide is saying, would you rather look all this up yourself, like I'm trying to teach you to do, and try to figure it out, or would you rather have a warning pop up when your patient is at risk of a drug-gene interaction? Do you want to play, Tammy?
Yeah, can I have a third choice? Can I have an Amber in clinic with me?
Yes. We'll work on justifying that position. But for now, without an Amber, I think a helpful solution is clinical decision support. And so here at UNC, we actually just rolled this out system-wide. We have a couple examples where we've built in pharmacogenomic clinical decision support. This is one we've built for CYP2C19 testing in clopidogrel. But in this case, it's a little bit easier in that maybe you didn't order the testing, maybe you're just ordering a refill or, just meeting the patient. These are pharmacogenomic warnings that will come up. A lot of them are inline warnings, so you don't have to necessarily click them all the time. But we'll give you information about, there's a drug-gene interaction and what you could consider. So in this case, you'll see at the bottom it says you should consider alternative P2Y12 therapy. So another would you rather test for individual genes one at a time and wait for results? Or would you rather test for multiple important pharmacogenes so you have the results on hand when you need to prescribe the drugs? Let's pretend like insurance isn't going to deny.
Did you know where I was going with that?
Yes.
Where my brain was going?
Pretend insurance doesn't exist.
Insurance doesn't exist. I'd rather two.
Okay. All right. Me too. So there are institutions who are doing multi-gene testing. So probably the leader in this field is St. Jude. We talk about insurance, their reimbursement structure is a little bit different. But at St. Jude, actually, anyone who walks through their door, they get a multi-gene pharmacogenomic test. And so they have this information on hand when they prescribe drugs. Other places like University of Florida, Vanderbilt, and North Shore have programs where they'll order multi-gene testing. And then my favorite one to bring up is actually the VA just implemented a national pharmacogenetic testing program where they're offering this multi-gene testing to any veteran who's interested. It's called the PHASER program. So I'm very competitive, so I'm trying to push UNC to be on this list, and so hopefully we'll be there soon as well. We're doing a pilot. Hopefully that will start this year in GI oncology. So Tammy's sitting next to me. She may not even know she's going to be in this pilot, but where we're going to try to look at feasibility of this. So we're trying to develop some of this clinical decision support, especially so that providers have the resources available to them and don't have to look this up on their own. So in summary, again, I talked about targeted therapies in oncology, and a lot of them now are requiring biomarker testing. There's lots of big panels. They're kind of becoming the gold standard. And so I think it's really important that you have some ability to understand that information. And the resource I like to go to first is that OncoKB. And then when you think about germline genetics, especially when you're talking about drug metabolizing enzymes, they can really impact how the patient responds to a lot of different drugs, including ones we use rather routinely. And my favorite resource there that I'd bookmark is that PharmGKB website.
Thank you, Amber. This was incredibly helpful. There are even resources, being in the field for so long, resources that you taught me. So thank you. If you have questions for Amber, please submit them through Poll Everywhere. We have a couple of minutes before we end this afternoon. So get your Poll Everywhere out to talk with Amber. While we wait for some questions to come through, I mean, we were, joking and laughing about insurance, but it's certainly a real issue. And being in GI oncology, super excited about being a part of this type of pilot. But can you talk about the challenge of insurance coverage? So even if providers are recommending this and think it's really important, why do we have such a barrier with insurance?
Yeah, so there was a shift a couple of years ago with Medicare. So Medicare actually shifted a couple of years ago to say that they would start to cover these multi-gene panels as long as you had an indication to do testing for at least 2 pharmacogenes. And so I'm specifically talking about sort of the second example with those pharmacogenes. I think insurance for the somatic testing, that's opened up quite a bit. But for the pharmacogenes, I think we're still navigating that. But there was a shift when Medicare started to cover, and I actually, a lot of the groups I work with, we partner with some of the big payers, especially in North Carolina, to try to talk through why these multi-gene panels, are appropriate in a lot of cases. With GI oncology being an example, you saw in that list, there's pretty good evidence for drugs like 5-fluorouracil, irinotecan, ondansetron, pain medications, and I think you can probably speak to you're using those pretty routinely in clinic. And so that's what this pilot is going to look at to sort of make sure that we can navigate those payer challenges. And the landscape has opened up, but I think, as you know, each payer has a different formulary, and so we're going to work to try to navigate that. But I think it's gotten a lot better. The cost of testing has come down, and I think a lot of labs are offering more robust patient assistance programs that can really help with access. My thought is that if we're going to ask payers to pay for it, we need to make sure we're applying it. And so that's where the clinical decision support comes in. We should be able to test these patients once, and then we need to make sure that we're using that information throughout the care continuum. So that's where having some of that infrastructure built out, I think, will also help support payers because they can see that we're using the information and it's not just getting put in a drawer.
Well, thank you for fighting the fight. And hopefully maybe companies like what's happening with NGS, right, that are helping support patients who may have trouble with paying. I mean, I think we answered the what is insurance reimbursement like. I've had denial of DYPD deficiency, for a colorectal cancer patient getting 5-fluorouracil. So I don't know if you have anything else to add about that or Yeah. So our next question, are there certain cancers you would suggest to always get NGS?
So, yes, lung cancer. Lung cancer is my go-to answer for that. But the long answer is that the recommendations are slightly different depending on the type of cancer that you're treating. And so it's not just cancer types, but also when in treatment we get the genetic testing. So for some cancers, we're getting it earlier in treatment, and then for others, we would actually, wait until later in treatment. So whether we're waiting till they're metastatic or maybe waiting till we have no standard of care options available. I would say, in my experience, in most solid tumors, we're getting genetic testing. There's not always FDA-approved therapies, but I think there's a lot of research going on in this space, and so if you want to evaluate if there's any experimental avenues for your patient, it's pretty routine. It's also pretty routine now in hematologic malignancies as well, so yeah.
Yes. And an additional question, so if not covered, what might out-of-pocket look like?
So for the germline pharmacogenomic testing, the out-of-pocket cost is generally around $300 or so, I would say, for most of these multi-gene tests. Usually that's like with no patient assistance. So oftentimes patients will also, that cost will come down if they have meet certain income eligibility requirements.
I think that wraps up our questions, and I know we are at the top of the hour. There was a compliment for your lecture in the beginning that was really helpful and informative. So thank you all for your time and attention in joining us this afternoon. Thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Center, and the UNC Lineberger Cancer Network, and to our amazing telehealth team who are behind the scenes making all the magic happen. Thank you to Tim, Venny, John, Oliver, Andrew, Patrick, Lindsay, and Barbara.